Hi, Deanne.
Hello, how are you guys?
Good. How are you?
Oh, well, thanks.
A lot going on.
Yep. I can't decide which data sharing, I don't know, strategy document to read first.
I know.
There's a lot.
Brandon's on. Welcome. A couple more minutes for folks to trickle in.
Oh.
Hey, Tom. Dolores is here. Good.
Hi there.
Hi. Okay, Kira, give us a heads up when you see it's a good time to start.
Right now is good, actually. Yep.
Okay, great. Hi, everyone. Thanks for joining today. We have a really packed agenda. We have the bulk of the day today. We want to talk about the data sharing agreement. And with such great work with Robbie and his team, I think we've got a really nice package to walk through. And it will prepare us well, I hope, in your organizations to be able to receive the final data sharing agreement that we expect to have out later this month. And then prep us for final comments that are due in early June. So here we are. We're here in, I guess, May 5th. Happy Cinco de Mayo, everyone. And we're also going to spend some time on the population health management update, or on the population health management system. DHCS recently gave us an update, and we want to relay that to you. And also there's opportunity for us to comment. So that'll also be a good way for us to prep a letter back on how we align with data sharing framework, as well as with the data sharing that's happening today in the state. Then we have some quick announcements. If you have any announcements, of course, use our chat to do that. I also welcome everybody to put your name and organization in the chat. Some of you are new, and it's always good to be able to network here as well. And if you can move to the next slide, Kira. For those of you who are joining us today for the first time, we're a coalition dedicated to advancing connected health data across California. And to do so, we are looking at how can we best take advantage of the data sharing that is happening today, while being able to bring in state support. The mandate that was passed yesterday, feels like yesterday, the mandate that was passed last year has really put us in good position. But now as a coalition, we are working to ensure that the data sharing framework, as well as the data sharing agreement, meet our needs. In addition, we are really focused on how do we cement funding, and I hopefully we'll have some updates on that as well today. So if we can move to the next slide. I think we've got a lot here today, but in general, our programming follows a blog post that we did last year, looking at all the different use cases that the data sharing framework advisory group launched on the why we need better data sharing, health data sharing in the state. There are really some commonalities among all those use cases. And so we kind of pulled those out. And in fact, much of the data sharing framework is going through each of these different key pieces. And that's what we're really focused on, making sure that we're pushing through our newsletter to you, as well as bringing you good speakers that we can learn from and be able to bring the best of the best and learn from others and best practices in these areas. And then we want to highlight the following two use cases. The first being around COVID-19 and a pandemic response, and really bringing in public health into the conversation and making sure that the work that we're doing includes public health. And then also all of the transformational work happening in Medi-Cal through CalAIM also is an underpinning of this work. So with that, I see some chats going on. Again, please go ahead and introduce yourself. And we really hope that this is an interactive day today. You're with all staff today. So we don't have to mind our P's and Q's. And Robbie is going to lead us through the work and the analysis. It's all in your deck. So you'll have this to be able to share with others. And then we would really like to be able to get this up on our website today or tomorrow. So we'll be doing a quick blog. So as you go through and hear this discussion, I do have some homework for you. Jot down what you think are the big key issues that you think we should really prioritize, or as a group we prioritize, because that will highlight that as the blog. We'll, at the end of this presentation, I'll ask all of you to put that into the chat. So some active listening here, and we really want to highlight, what are the key things that must be done, or we may not be able to get to the data sharing agreement that we'd like to get to. So Robbie, I'm going to hand it to you.
Thanks, Timmy. Yeah, and I think if folks have any thoughts or ideas or questions, or contributions, feel free to jump in, raise your hand, put it in the chat. We'd love for this to be interactive. But as Timmy said, we really want to dive into the data sharing agreement. And just to refresh folks' memories, so the last subcommittee meeting, or not the very last, but the most recent one was last week, where Cal HHS, released full, complete versions of the data sharing agreement and associated policies and procedures. So you can see in here in the blue table and the red table what was released, what were the different areas of subject matter that they touched on in the DSA, in the policies and procedures. The orange and purple ones are areas for future development where they'll either add some more color in the DSA or create new policies and procedures. So these are all the topics they went over. The meeting last week in the subcommittee, I think, was really robust and informative. Weren't able to get to kind of every single subject within the DSA and the NPs. I think we've tried to incorporate some of that feedback into our analysis as well. But if there's anything maybe we missed or you think we should be adding, please make sure to let us know. So we'll move on to the next slides, and apologies for the text heaviness. Timmy and I spared you our even more detailed Word doc, but we really wanted to put in what's in the DSA or the PNP, and then kind of pull through in the comments and feedback. How does that compare to what's in AB 133? What are some of the issues that might be there in terms of alignment with HIPAA or CMIA or other state laws, and maybe what are some recommendations too? So to start with, the definitions of data that's to be shared, the DSA lays out references to health and social services information, largely pointing to the definition in HIPAA of protected health information, as well as personally identifiable information. And really a couple of points we noted here. One thing was, is there a need under the umbrella of health information to share PII under the auspices of the data sharing agreement? Or is it really just PHI that should be shared? Is there a need to be sharing email addresses, social security numbers, data that's in a CRM outside of maybe what's really necessary to share that would be PHI? Another item we noticed too is that the definition of PII also references the CCPA, which doesn't apply to most of the folks who will be sharing data under the DSA. So that just seemed like one little thing to flag. I think as well, the scope of social services organizations and their inclusion under the DSA, that came up last week. Should HIPAA apply to social services organizations, and what does that mean? I think there still is, uncertainty out there for a lot of covered entities under HIPAA, whether they can share or disclose data to social services organizations. OCR has flagged that too, and they're looking to hopefully make some updates to HIPAA to clarify that, disclosures can be made to social services organizations if it's for treatment without authorization and the application of the minimum necessary standard. But, those uncertainties still are there as well. And, a couple recommendations we wanted to bring to you all, is there likely a need to remove the reference to PII? Is that necessary? What's the reasoning for that? Maybe note too the HIPAA rules and exceptions for disclosing social services information. Could that be maybe clarified in a PMP for participants? And then to just consider whether there's a need to remove references to both health and social services information if, HIPAA is not going to apply to these social services organizations. Is there a need to kind of lump all the information together under the DSA? So we'd love to hear if you all had any thoughts on this topic in particular. If there's anything maybe we're missing in this section.
Robbie, this is Deanne. Are you still on the first section, definitions of data to be shared?
Yeah.
Okay, thought so, just want to make sure. Because my eyes love the first one below the line.
Well, we could jump to that one too. And around a duty to respond. So there's language in there around a duty to respond. We were thinking, AB 133, looks to get the state more towards real-time data sharing. So is there a need to, include some sort of standard for response times? I think we're curious, all of your thoughts on this. I think where our heads kind of went was something that's like a reasonable standard, a reasonableness standard. A month seems like a long time to respond to a query, but maybe a day is a little bit quick of a turnaround. So, would welcome any feedback, or Deanne, if you have any thoughts on this too.
Well, I naively was focusing still mentally on real-time data sharing, and nothing that I read in the draft DSA is promotes real-time data sharing from what I read. Health center minimal level feedback, especially for the time constraints and whatnot of responding and reading last week, was that it's another data sharing agreement. Like, not that feedback was kind of like, yeah, it's a data sharing agreement. It's not driving any significant, it won't drive any significant change.
Mm-hmm.
This is Judy Nightingale. I agree 100% with that statement.
Deanne, do you have any thoughts for how the agreement could be improved to promote more real-time data sharing?
Probably finish the framework first.
Yeah. Well, and maybe too, I know we're going to get to some other topics as well around proactive data sharing and qualification of intermediaries, which I think is related to that. But are there any other thoughts on maybe initial thoughts on how real-time data sharing can be incentivized, I guess, under the DSA?
I think, Robbie, we are recommending of a reasonable standard for time to response. So it's more of there needs to be a query and need to be a response versus any type of a push, right?
Mm-hmm.
That has been like under the meaningful use years and then 21st Century Cures Act, kind of a very consistent people wanting to know what the parameters are around timeliness. And I don't know if anybody has ever said this is it. Meaningful use even actually seemed to get away from it. Like it was more defined and got a little more gray over the various stages and things like that.
Mm-hmm.
And then for the first section, the data sharing, the HIPAA notes and everything, I also felt like the DSA seemed to be inconsistent, going from talking about HIPAA rules are going to apply to everybody who signs this DSA. And then in other sections, it was like, no, not really that.
Agreed.
So that's some of the comment I submitted to CDII.
Robbie, I'd like to elaborate on my comment.
Mhm.
This is so. I mean, we already have, a system where our healthcare. I'm speaking from the case manager from the health plan side. We are mandated to capture data points and engagement with our patients. So having this alignment where we see when they've accessed social services, and if we could assist each other and if they could follow the same playbook that we have to follow with HEDIS and compliance and HIPAA and everything else, why not everybody follow the same playbook? And then we all round up into this population health, because that's what we're talking about, population health management, into managing it better so we know where the outliers are, and we'll be able to grab big data from this. And that's my comments.
No, that's helpful, Doug. And especially thinking too about, the instances of sort of social services, like services that are already, subject to HIPAA too. Any
Robbie,
other?
are you monitoring the chat here?
Yeah, I see. Will the social services data include programs, potential eligibility, justice involvement? Those are all great questions. I think it seems like those are all, generally contemplated, but kind of devil's in the details in terms of who signs on to the DSA, partially because right now the mandate is for health plans and providers, but social services, CBOs, are not mandated to participate as of yet. And Katie, good comment too around the reasonableness of requiring all entities to be subject to HIPAA. I think that's a good point that folks have brought up in the subcommittee, and I think we'd be curious if other folks had thoughts on that too.
I think I think that would be a reasonable expectation if you're going to be part of the data sharing work.
Mm-hmm. And that's a good point too, Stephen, around the information blocking provisions in the duty to respond as well.
So Robbie, could we then replace the reasonableness with queries without delay?
Yeah, that makes sense. It's a great suggestion. Any other thoughts? I see, Katie, you have your hand raised.
Yeah, thanks, Robbie. Just to elaborate on my comment, further down in the comments in the chat, I know the difficulties having been at the state of motivating folks to share data, even across current health systems, whether it's public health to health to mental health, et cetera, and the need to sort of say, you shall share this data. But we do hear that community-based organizations, a huge barrier for them is HIPAA compliance. So I agree, I think some folks are saying maybe there's some solutions that aren't necessarily full HIPAA compliance. Just an example, the Department of Social Services at the county level for CalFresh enrollment can access what we call Meds Lite. So they get into the Medi-Cal enrollment system. And it's not full access to the system, but it's kind of a light version. I don't know what the options are, but just knowing that for smaller community-based organizations, I think there should be absolutely an expectation if they're participating that they have to share this data, but trying to just acknowledge that it is a big barrier for them. And is there a way to bring them online in a easier way or support them in that, some capacity building, funding for getting to be, working with maybe there's a vendor who could work with 10 or 15 CBOs at a time to get them compliant, something like that. Because I think they all want to, it's just a big barrier for them.
That's a good point, Katie. And I guess a related question, and that seems to relate to as to whether, HIPAA should apply, right? If that is too burdensome for those organizations that don't participate.
Can I ask for clarification when you're saying HIPAA is going to apply? Because it's obviously applying to the medical information being shared out to them, right? And that's where you're talking about the TPO exception. But are you saying that the social services information being shared with medicine would be subject to HIPAA?
Yeah, or even it could be if you're, say you're a CBO who's a signatory and you want to share data with another CBO. That I think that's like another use case, right? Where today HIPAA wouldn't apply unless
Correct.
you were a covered entity. But then if the DSA says HIPAA applies to everyone who signs, then does it, and then, well, to your point too, I think there's confusion. How does that functionally work, right? How do you fit different social services data sharing use cases within the HIPAA framework? And then, as was brought up at the subcommittee meeting, you know, OCR rules only apply to covered entities and business associates as described under federal law. So what does that mean for everyone else? And what does guidance look like? And it seems like it could lead down a rabbit hole in terms of trying to apply those standards to organizations it's not really meant for.
Absolutely. I wouldn't recommend that.
And Mary Sarah? Oh,
Well, excellent. Any other thoughts on these two topics at all?
I'm sorry, this is Mary Sarah. I
There-
fell
there
off
you
there
are.
for a minute. Yeah, sorry about that. I think we need to be really careful to differentiate the system that's the origin of the data and what are the policies that apply to that. So HIPAA is not going to apply to the CBOs, the system of origin. And then you have the means of exchange. And then you have the means of sharing the data. So the data could get integrated into another system. And then you have the issue is that HIPAA compliant or not. And then you also have the exchange, which of course is going to have to be HIPAA compliant. But the exchange could actually also have a portal to share that data. And it could, in that case, stay HIPAA compliant for the CBOs. So if we break it into kind of the components of where does HIPAA apply, I think that kind of opens the door. So then you're even allowed to have a CBO sharing data with a CBO via the exchange, which is HIPAA compliant, in which case the sharing is HIPAA compliant, but the CBOs are not.
Mary, I would love a visual of that.
Okay, all right, I can do that.
Thank you. I'm sure you have it.
And that's a fair point too, Mary Sarah, around
Okay.
the integration of the data. And I think we'll get to that point in just a second too, in terms of some of the restrictions on secondary uses of data too, that might complicate things as well.
Yep. Yeah. And the other part of that is the provenance. You know, you really want to protect where did that data come from? Because data means something different depending on what was the situation and the originator of that data.
Yes, and Katie, thank you for the piece too on why the data is being shared. I think that's also a key issue that came up in OCR's notice of proposed rulemaking last year around the application of, you know, HIPAA and for different exchange purposes and where minimum necessary applies and things of that nature as well. Maybe we can move to the next slide. So relatedly, required purposes. So what's in the DSA? They exchange that participants are required to exchange health and social services information pursuant to the framework for treatment, payment, and healthcare operations and public health activities. But then in the definition section, just list a subset of healthcare operations, use cases in there, particularly around quality assessment, improvement activities, as well as population-based activities. You know, AB 133 kind of generally references TPO and doesn't get into a subset. And then as well, you know, HIPAA restricts certain disclosures for recipients, operations, and payment. You know, how does the agreement anticipate some of this being implemented, especially around disclosures of social services agencies? Because, you know, as was mentioned often, you know, HIPAA doesn't allow for all disclosures of PHI to social services agencies, especially without authorization. And then additionally to around real-time data sharing, where that should occur as well. So a couple thoughts here around recommendations, requiring responses for all TPO purposes. I think we'd love to hear feedback on that. How to accommodate certain HIPAA issues implicated with sharing with social services. I think we touched on a few of those already. And then, is there a need, and maybe this gets to your point, Deanne, around proactive data sharing? Are there certain use cases where there should be a required purpose to proactively share versus sending a query? So I think we'd love to hear folks' thoughts on any of those points.
Looking at the,
Well, will they be sharing information about justice involvement? And if so, that will likely be require CGIS level of management of policy, and that CGIS is actually much more stringent than HIPAA. So it's important to think that HIPAA is not actually the most difficult. FERPA and CGIS are much more difficult to maneuver around. And if we're going to bring that data in, then I mean, that's going to actually change some of your architectural decisions.
Yeah, there are mentions in there that, participants are subject to all applicable law for their respective organizations. So I think any laws that pertain to a specific participant, including or beyond HIPAA would apply as well. Do folks have any thoughts around, treatment, payment operations, and TPO sharing for different purposes and the limitations that were included in the DSA?
I think we'd note that we have some consuming of this, but you can always send us your comments. And as I mentioned at the beginning of the meeting, this is really to get our juices flowing. The timeline is we'll have the ability to give feedback in June, right, Robbie? So I think this is great, but if we're not going to be able to get the feedback right now, we can get it over time too. I think our recommendations are to require responses for all TPO, correct, Robbie?
Yeah. And then I guess another question too is around getting towards real-time data sharing, as was mentioned at the outset. Are there certain needs around not just querying for data, but for proactive data sharing for things like ADTs or public health, where that should take place proactively versus via requests for data? Any thoughts on that at this point?
Well, there are clearly stakeholders who are super enthusiastic about ADTs, just like send me all the data. And then you've got a lot of folks in the community that really want it to be more on an as needed basis. The nice thing about getting data in real time when you need it is that you get the latest data and you're not just looking in the rearview mirror at things that happened in the past. So I think it is an important differentiation, and there are clearly folks who advocate for one or the other.
Definitely. And I guess related to that, is there a way to kind of line up those requirements with, say, like under the CMS rule around, sharing ADTs with PCPs of record or health plans?
Well, the CMS requirement is very specific. When people talk about ADT, they're, a lot of them are talking about a very rich data feed that can include all sorts of information. The CMS requirement is simply a notification of the admission discharge transfer, and I think that's something obviously that everybody, all of those who are covered by the CMS rule, the hospitals in particular, are already comfortable doing. And it's really up to the patient to identify who are their relevant caregivers. So it's a different thing when a sort of a third party, that just says, send me your ADT.
Would it be functionally difficult, I guess, to require, submission of, more than just a simple notification, but maybe like a discharge summary?
I mean, it's not difficult. It's just a whole different thing, right? I mean, everybody to comply with the CMS, the ADT notification requirement has built their systems to do that, right? Very different than sending a discharge summary or other, more dense clinical data feeds.
That's a good point.
I think maybe this is something that can be taken up in the policies and procedures, be able to accommodate different use cases. I just want the data sharing agreement to be able to accommodate really urgent use cases without having to go through 6 months of refinement. So there needs to be some level of alerts put into, I think, the use cases that this is covering.
And Doug, you have your hand raised, I see.
Yeah, I just want to point out from a user exchange standpoint, those discharge summaries aren't always available at the time of discharge. So sometimes we have to wait 2 to 3 days to get that from the hospital EHR. But we could make a requirement around the timeliness of that. We have timeliness with URAC standards for our authorizations and everything else. If we had a timeliness for the sharing of that data with where that patient is supposed to follow up and put that in writing. And so everybody's clear. We have all these vagueness in a lot of our policies. I think we should define it a little bit better. That's it.
No, that's helpful, Doug. Great. I think we can move to the next set of items. So data elements to be exchanged. So a lot of the DSA really draws from what's in AB 133. And in there, they point for health plans to specifically to the CMS final rule and in the Federal Register, as well as for providers to first US CDI through October of this year, and then moving to the definition of EHI thereafter. So I guess one recommendation to cite to the regulations versus the Federal Register, should they change, would just be one recommendation to make sure that the standards in the DSA don't become obsolete. But another is around thinking about the definition of EHI and designated record sets. That covers quite a bit of data that providers may have. And as well, under the CMS final rule, there are a lot of specified types of data that payers or health plans have to share, ranging from US CDI or claims to encounter data, depending on the part of the rule. So a couple of thoughts on recommendations there. Are there specific types of data that the DSA can specifically call out in order to make sure that health plans and providers can comply with the requirement? So, right now there are specified, data elements and types and messages specified in a P&P, but kind of calling out, you're in compliance with these requirements for the data elements to be exchanged, and being explicit around what kind of data is anticipated or expected to be shared by both providers and health plans, so that there's not as much, I guess, ambiguity in terms of what needs to be shared. Did anyone have did other folks have any thoughts on this or on these definitions or anything of that nature? Okay, well, we can continue to take in some feedback on that too. The next item was just around minimum necessary, and I don't know if other folks caught this too, but they don't perfectly cite to the HIPAA minimum necessary standard. There's some extra language in there around, except where limiting such use or disclosure to minimum necessary is not feasible or required under HIPAA. And it seemed kind of like that statement's not necessary, because if minimum necessary is not required, then feasibility is not really an issue. So just kind of, right, suggesting that the DSA really just kind of cite to what minimum necessary is under HIPAA versus kind of adding extra language. Another topic on the next slide is around financial interests, and curious on folks' feedback on this too. So under this section right now, there's language saying that participants shall not for their own indirect or direct financial benefit reuse, redisclose, aggregate, de-identify, re-identify, engage in the sale of information being shared. It seems like this provision, goes beyond current federal and state law when it comes to reusing data in many ways, but that the financial interest provisions may restrict, for example, a recipient using that data, that may have been requested for treatment purposes to then, use it to submit a claim, right, as a financial interest. It also seems like just more generally with this provision that it may not be so feasible for organizations to be able to tag that information being exchanged and subjected to the restrictions under the DSA. And specifically, there's also a little bit of confusing language around these provisions not necessarily applying to business associates as well. And so just, I guess initial thoughts on recommendations, maybe to remove the financial benefits reference in whole, and really to cite, HIPAA and state law prohibitions or rules when it comes to secondary uses, and not add additional provisions on that subject. Did other folks have any thoughts on that?
I agree with you. I mean, we need to not limit it. And I mean, think of all the clinical trials and the big data, aggregation that's going to be done with this information. Who knows directly or indirectly if there will be a financial component, and that's just going to muddy the waters. That what if there is indirectly, but this entity didn't know that, or was, knew that from the start, but they got it indirectly.
Mm-hmm. Yeah, and relatedly, what are folks' thoughts on the feasibility of tagging all the data that comes through under the auspices of the DSA?
Well, are participants going to be notified as to how their data is being used? Or patients, are they going to know? So if their data is being sold, are they going to know? Or if it's being used for research?
Well, this provision would kind of prohibit much of that, Mary Sarah. So there's no notification provision, but I think it's written right now that you really wouldn't be able to do much of that under the DSA.
Right. And I was just responding to Doug's comment and wondering, okay, so if you did remove it and we do have all the clinical trials and all, do people have the ability to know how their data is being used? Kind of like following along with GDPR, which does require the ability. And we're seeing that from a policy perspective. Be able to opt in and opt out. And so thinking about how does that apply here? And even if it doesn't today, is it going to in the next 3 years? Because if that's the direction that we're going into and you remove it and data is used that way, again, that's going to become an architectural consideration.
Yeah, that's a good point, Mary Scott.
And that would be easier to do at the person level than at the data element level. I'm just thinking out loud. It's a great recommendation.
But that is a really good point. The idea that individuals should be aware when their data is shared via this, this framework, and then reshared. I mean, that's the other thing, of course.
Right.
The whole issue of provenance. Not only where did this data come from, but where is my data gone?
Right.
Yeah. That makes sense. So maybe rather than a prohibition, a requirement to allow individuals to find out where their data is gone.
And of course, HIPAA has certain requirements, on covered entities for, being able to account for use and disclosure, but it's limited. You know, it's much more limited than what we're potentially talking about here.
That's a good point too. Great. So another, I guess, moving on to other topics too. So breach notification, and this came up in the subcommittee around the standards that were proposed. You know, right now there's language in there requiring a breach notification with no later than 2 days after determining it's occurred if a participant needs to notify the breach to the governance entity. In addition, you know, no later than 10 days after determining a breach has occurred to provide notification of the breach to other affected individuals or entities. You know, I think at first read 2 days seems like a tight turnaround and is higher than, you know, the standards under federal or California law. And as well, you know, just, you know, other related issues around the need to provide a breach notification, right? You know, under the health and safety code, you know, you don't have to report a breach if a risk analysis concludes there's a low probability that data has been compromised. And then too, just also around, you know, reports to affected individuals and the standards there. And, you know, here there's a standard as to whether a breach is likely to have an adverse impact on a participant. So, you know, what would that mean functionally? You know, how would a participant assess whether another participant has been affected or impacted? You know, what exactly do those terms mean in this context? So, you know, initial thoughts are really to kind of align with breach notification laws as they currently stand under federal and state laws, and then, you know, really just cite the HIPAA definitions when it comes to access and acquisition and unauthorized, and just make sure our terms are kind of fully defined throughout the section. Stephen, I see your comment. There's no good reason to incorporate more stringent breach notifications. I think that was kind of our assessment too. Any other thoughts on this section from folks?
We got agreement.
Cool. Great. Another key issue is just around the ability to make amendments to the DSA and the PNPs. And the proposal was to, you know, have a 30-day standard to review and approve amendments and 30-day calendar days for them to become effective after, you know, they're published and signed. And I think there is discussion to extend this to 180 days to allow for, you know, sufficient input from stakeholders as well as for implementation. That 30 days is a tight turnaround, especially if, you know, the policy and procedure tackles a large issue that requires a lot of changes to systems. But curious if folks had other ideas on standards here or timeframes. I think this was the one that was floated in the subcommittee. All right. Well, feel free to share your thoughts on that one with us too, if anything comes up. So lastly, on our last set of topics on the next slide. So around qualified intermediaries, the DSA, you know, mentions that participants can utilize, you know, other entities to help share data on their behalf, but doesn't go into too much detail in terms of what that means or how that can be done. You know, specifically kind of like what that looks like functionally. And some of the ideas that came up were to, you know, create a directory, you know, with endpoints so folks know where to, you know, route an individual's data and things of that nature. So I guess a couple recommendations, you know, make it clear that sort of these qualified intermediaries can respond to requests on behalf of other participants, and really to define them and clarify that they also are participants in the data sharing agreement. And then also to set certain requirements for what that means to be a qualified entity. So something along the lines of what DHCS used for qualifications, for the CalHOP program, and that the state has kind of already outlined in terms of what a qualified intermediary is. And then also to just think about how whatever the setting, equivalent kind of technical requirements to ensure that, both intermediaries and participants can share data under the DSA and what that looks like and what that means. So curious if folks had other thoughts on the topic and qualification and, using another party to share data on your behalf.
This could be aligned with some of the federal stuff where with sharing under the FHIR, FIHR, for medical records. If you wanted to take a look at that, I'll look for my reference on that.
Great, thank you, Doug. Felix?
Yeah, thanks, Robbie. Can you maybe just flesh out a bit more the very last bullet that's shown here on minimum technical requirements? Just maybe go a little bit deeper on that and what you're thinking there is.
Yeah, I guess, what does it mean to be able to share data under the DSA? Like what, especially if you're a qualified intermediary, what kind of functionalities do you need to have to be able to meet the obligations under the DSA to be able to share data on other participants' behalf? And I guess similarly for participants to be able to share on their own behalfs, what functions do you need to be able to serve to be able to share data or receive data? Is it merely, I guess, having an EHR? What does the state foresee in terms of what kind of capabilities participants or signatories need to have?
Okay, thanks. That's helpful. So my comments just following up from that would be, I think a lot of people would agree that it doesn't make a whole lot of sense or may not be appropriate to go into the nitty gritty about like specifications of what does or doesn't count for these minimal requirements. But I think the overarching end goal, right, would be at the end of the day that whether you choose an intermediary or whether you choose your own technology, your own means to directly share data on your own behalf as a participant, whichever mode or path you decide on, that there has to be an assurance, right, that those two options can talk to one another and will talk to one another per the agreement and per the framework. The example would be if a small practice decides to sign up with a qualified intermediary that's a regional HIO, and they want to delegate all of their querying and pulling of requested data from other entities, as well as responding to requests from other organizations, that intermediary is able to do so, whether they're talking to another intermediary or whether they're talking directly to the participant on the other end, if they're using their own technology. So like if a hospital wants to use direct message or just something that's outside of a intermediary framework, like it still has to be able to get to the HIO so that we can relay it back to the practice, right? You see what I'm getting at? Like, I think, maybe hearing you talk it through, I think that aligns with that concept, but if so, I think the language could use a little bit tweaking to maybe make that more explicit.
Yeah, well, and I wonder too, if to your point around not getting too in the weeds, if it's like a warranty in the DSA, that participants warrant that they have the technical capabilities to be able to share and receive data under under the DSA. And, you know, maybe it's leave it at that. Maybe we can think through what specifically this means in more detail too. Mary, Sarah?
Yeah, I'd encourage you to change it a little bit to the ability to access and share data instead of receive. And I think that'll get rid of some of the technology hurdles.
That's helpful.
Because I don't think everybody's going to be accessing in the same way, right? We want it to be able to be consumed by EHRs, so that would be receiving, but some of the CBOs are not going to receive it. They're going to access it via another mechanism, most likely.
That's a really helpful point. Thank you. And I guess too, just a couple other items just on the final slide that we flagged to, just in terms of other potential issues that we just didn't put into tables, just around some confusing indemnification language under the liability section, some missing definitions for terms, you know, excerpts where it doesn't seem necessary to include them versus just kind of cite HIPAA. And then around individual access and accommodating exceptions under HIPAA. And then just some, you know, potentially missing items, just enforcement provisions. What does it mean if you don't meet your duties under the agreement? Certain references to other applicable laws that might apply in certain cases, like LPS or 42 CFR Part 2. Another item that came up in the subcommittee, as was mentioned, was, you know, a directory for endpoints or a record locator. And then also to, you know, thinking of like, is there a need to create a standardized patient authorization that can be used by participants that meets everyone's needs under various laws to ensure that, you know, authorizations are collected in a standardized way? Are there any other thoughts on items that may have been missing or other potential issues with the DSA as drafted?
Will there be a oh, I'm sorry, go ahead.
I'm just saying, is the API endpoints include the HTTPS endpoints and stuff like that? Or are we going to see a directory of that too? Is that what you're asking?
Yeah, I think so. Yeah. Like where if a participant, say, is designated in a qualified, you know, intermediary, where does the data get sent? Or did the participant write? And Mary, Sarah, did you have another comment too?
I did, and I just lost it. Oh, consent. Will there be a consent provision?
Oh, that's a good question. It doesn't look like it right now, but they have mentioned creating a consent registry under the digital identities work.
Okay, and I would just suggest that be consent of what data with whom, so being able to specify the data and who may access it, and that it be editable or revocable by the patient at any point.
Okay. Yeah, we can look to add something around that as well.
Let's jump to the timeline, Robbie.
Yeah, I guess just in terms of next steps, so new drafts are going to be shared of these documents on May 11th. And then public comments will be due on June 1st. And then July 1st is when, you know, the final drafts will be released. So there'll be opportunity after the next drafts are dropped for all of you. And, you know, we hope the coalition too to submit comments and feedback to the DxF group.
So this has been really helpful. We're going to have to weed through the text, and we'll incorporate the feedback that we've received here into what you see here today. And then we'll also post it up on our website so that hopefully, share it widely with others. I think that, everybody's kind of rolling up their sleeves right now to see if they need to get ready for this public comment period. And then we'll have one of our next meetings. We'll make sure that we I think our next meeting is like right after it gets dropped on the 18th. So we'll have to turn around a quick letter for all of you to review before it gets sent in. Did I relay that correctly, Robbie?
Yeah.
Okay. Okay, great. Well, I hope this has been helpful. And again, thank you so much, Robbie, for all this work and analysis. It's tough to do. And I think it's really helpful for all of us and all of us as stakeholders to getting this right. So I'm looking at our time. We have just 5 minutes, but I do think it's really helpful to get on all of your radar that DHCS did release its draft population health management strategy and roadmap. I think we should just move all the way over to our insights on that, Robbie.
Yeah. Yeah, I guess we can kind of zero in on the piece of it. Really, I guess next slide, DHCS is really looking to build out a population health management strategy that, you know, gathers member information, including things like screenings and different types of data, really to help with risk segmentation and stratification, to then, you know, have that available for managed care plans and Medi-Cal to tailor services and supports to beneficiaries. And just on the next slide, you can get a snippet for the types of data that they're looking to be able to, you know, pull into this PHM service that they want to you know, acquire. And it's pretty extensive in terms of what they're hoping to leverage in terms of data. On the next slide, you know, as was mentioned, they're looking to procure a vendor that will serve as this PHM service. And, you know, individuals will be able to access it, providers as well. They'll have this open source risk stratification and segmentation methodology that they'll create as well. And really their hope with this is to improve population health for Medi-Cal plans and beneficiaries, and improve quality on a couple of key metrics, including things like maternal health outcomes and youth behavioral health and the like. And really on the next slide is the outline in terms of, you know, what's next. So they're looking to test launch this early next year over the first 6 months with some select partners, require participation from all plans in it in July 2023. And, you know, they're looking to kind of have those priorities and capabilities kind of continue to evolve over time. There is no vendor yet, as far as I know. I haven't seen the procurement go out for it yet. How is the PHM coordinating? That's a great question. Well, so in addition to those bullet points we just showed on the next slide, you know, these were some of the considerations we kind of have flagged. So, you know, there's a lot of data that DHCS is looking to pull into this PHM service to make it successful. How are they looking to, you know, leverage HIOs or providers and EHR data to make this a reality beyond just the claims data that they have? How, you know, they're working on the data exchange framework. How does the department look to, you know, utilize that agreement to, you know, receive and share data? How does that kind of, how are they contemplating that within their strategy around the PHM service and being able to collect data? And I think that speaks to your comment, Katie, around coordinating with CDPH and county departments of public health as well. And also to, you know, plans and providers are going to need to develop, you know, new systems and workflows to collect and share these data for PHM purposes. So is the state looking to make any additional investments to support plans and providers in this effort beyond what's been allowed so far? What kind of plan do they have for, you know, ongoing maybe incentive funding or financial support? Any questions or thoughts folks had about the PHM that you might have thought about in terms of reading the strategy document?
I think it follows along, but, you know, when I see this, Robbie, and you know, I probably already knew about this, but, you know, population health, these type of strategies that the state rolls out, you know, they did this before with the CalMedi Connect program and with the long-term supported services and the health plans having to ramp up and develop those strategies and present that to the state. And what were the outcomes? We still have, you know, that revolving door with skilled nursing facilities and lack of you know, follow through with in-home supportive services and everything else. So, you know, we're not seeing any outcomes from that. There has to be, I mean, I understand the carrot, but there has to be the carrot and the stick, and they need to incorporate that into this population health thing.
Yeah, that's helpful, Doug. In terms of, I guess, the accountability piece, we can follow up on that too.
Absolutely, accountability, because, you know, the eligibility only lies with one plan, and we need to follow up with that accountability. We know where most of that goes, but, you know, there has to be some follow through.
Yeah, there is a requirement for the plans to submit these population and health management plans to the department, you know, relying on the data that's included in the PHM service. Katie, I see your comment. This really needs to be coordinated with CDPH. I think you're right on that too.
So we have a timeline on this, right? To be able to get the comments in the next 2 weeks.
Yeah, there is an opportunity for comment by May 16th for stakeholders.
And the coalition, I think we want to be able to make sure that we get a letter in to highlight at least these 3 areas, and then also pull in the other comments that we're receiving here. So we'll draft a letter and pull it out, or send it out to all of you for review.
Excellent. And I know we're at time. Just two quick. Thank you for the help, Katie. I think just 2 news items to highlight on here. New blog is out around funding needed. Timmy authored that. On the next slide, there was a hearing on Monday around a DHCS budget change proposal related to interoperability, and questions were raised around kind of how that ties into the larger strategy around the DxF and funding, and ties into the support that's been expressed for, you know, Medi-Cal performance payments to incentivize participation in HIE. So there was a robust conversation around that, and I think we'll see what comes out in the May revise later this month too from the governor's office around funding, especially using MES funds for incentives. Felix, was there anything you wanted to add?
No, just a shout out and a thank you to everybody on this call who made it into the queue and actually, you know, got into the public record in echoing, you know, the points that Dr. Wood was making, and obviously uplifting our data sharing equity proposal. It really means a lot to have that solidarity and that support.
Awesome. Thanks, Felix. And one other update too, just really quickly on SB 1033. CPEN couldn't join today, California Pan-Ethnic Health Network, to provide an update on the bill. But it looks like it's going to be placed on the suspense file in appropriations and won't be heard until May 19th, at which point we'll know whether it's advancing this session or not. And this is the bill that would require health plans to collect, you know, SDOH and race and ethnicity and SOGI data amongst others, that the coalition wrote a letter in support of as well. And with that, I think, Timmy, I'll hand it back to you.
Well, thank you, everyone. Thanks for hanging in there for this discussion. And I agree that the time really flew by, and I didn't want to cut it short. So I did put in the chat, if you all want us to put in another follow-up call to be able to go even further in the DSA, let us know. We're happy to do that. And, you know, it's definitely something that we're going to continue to pursue and collect feedback on. So, you know, it's time to lean in. And we only have, I guess, you know, less than 30 days to do so. And let's continue to give the support to the state to get it over the finish line. And I think that's it. Our next call, Robbie, we had a slide, I think, on our next call. We should just
our next call
everybody
joined by Lisa Berry from Civitas Network. So and
I'm sorry I cut you off. It's on May 12th, right? No.
May 19th.
May 19th.
Yeah, 2 weeks. And then in early June, we'll be joined by the Cal Mesa group. We'll be talking about the semi-statewide enterprise EHR project for county mental health. So please make sure to tune in.
And thank you. And any announcements or any events, please send them to us. We'll put them in our roundup. And I just cut somebody else off too.
Oh, sorry about that. I cut you off. But yeah, I'll be out of pocket. I'm traveling to Florida for the Case Management Society of America, but we do have our California chapter, and I'll be bringing all this to the table for them because I do want their involvement, because we're the nurses that are kind of trying to connect the dots for all these patients. So whatever we can do to help, please let me know.
Thanks,
Thank you. Thank you. And we encourage you all to take it back and give us back your feedback too. And thank you all of you who have shared your comments as well with us. It's really helped. All right. Thanks for joining us today. Have a great day.
Thanks,
Take care.
everyone.